So the adrenergic is like the sympathetic nervous system, so there's all the potential effects, which really just means everything that could potentially happen if you activate the sympathetic nervous system. All of those things are possible. And so some of the careful with the day driving, being sure to increase fluid intake and sucking hard candy because of the dry mouth and constipation. And then the cautions related to those potential side effects. And you can see that this area here that's white matches this area, which is white, which is anticholinergic. So in this particular type of response, we're blocking the cholinergic receptors, which is similar to activating adrenergic receptors. The only difference you can see between adrenergic and anticholinergic is that it's only in anticholinergic medications that you need to avoid in myasthenia gravis. Because remember, myasthenia gravis is a condition in which people have an autoimmune response and some of their skeletal muscle cholinergic receptors have been damaged. And we have cholinergic receptors that are activated in the parasympathetic nervous system response, but the skeletal muscle also has cholinergic receptors on it. So the potential is if we block cholinergic receptors that's supposed to be blocking the parasympathetic nervous system response, it's possible that we might have some crossover that would affect the cholinergic receptors on the skeletal muscle. And since they already have weak muscles, we don't want to make them weaker. And that's always a test question, so be sure that you remember that difference. And then cholinergic is acting like the parasympathetic nervous system. Potential effects are all the things that could happen if the parasympathetic nervous system is activated, and then things you want to, or types of patients that will need to be cautioned about using those medicines. And then anti-adrenergic, or blocking the sympathetic nervous system, is going to be similar to activating the parasympathetic nervous system. Not completely, because it's different receptors, but it's similar. So you'll see that they are grayed out to kind of help you remember that they go together as well. So any questions about the sympathetic and parasympathetic nervous system? Because then we're going to move on to begin our discussion of neurodegenerative medications. That's the first part, and then seizure medications. Okay, so this is on the slides that are labeled medications for neurodegenerative disorders and seizures. The first thing we're going to talk about is neurodegenerative disorders. So that means something inside of the brain, nerves inside of the brain are being damaged. The first disorder that we're going to talk about is Parkinson's disease. So Parkinson's is a disease of a part of the brain called the basal ganglia, and the job of the basal ganglia is to smooth out movements, help relax after the muscles have contracted. It helps to relax or stop the movement so you don't overshoot or overdo your movement. So all skeletal muscle movement is sort of a balance. So when you start a movement or plan the movement, that happens in the frontal lobe of the brain, and that is a cholinergic response using acetylcholine. The smoothing it out and helping relax the movement after it's finished is in the basal ganglia, and that receptor is dopamine. So in order to have a nice, graceful, smooth muscle movement, we need these neurotransmitters to be in balance. We need the acetylcholine to initiate the movement. We need dopamine to smooth out the movement so there's no tremors, and then help relax the muscle when the movement is over. When people have Parkinson's disease, they have damage in the basal ganglia for whatever reason. It could be genetic, it could be from multiple trauma or drug use, it could be from all kinds of different reasons. But destroying the basal ganglia means you have decreased the amount of available dopamine. So the scale is out of balance. Acetylcholine, the production of acetylcholine hasn't increased. It's just that we've lost the balance from the dopamine. So the medications are aimed at increasing dopamine. The symptoms of Parkinson's disease are having difficulty starting a movement, having your muscles be very rigid, having tremors, especially when you're not moving, making you sort of lean forward so you're a falls risk, and have a very flat affect, or you can't really tell what the person is feeling by looking at their face. They are experiencing emotions. They still, especially in the early part of the disease, do not have any issues with cognition. They will, over time, start to develop those types of issues. Later on in Parkinson's disease, they can develop dementia and other psychologic problems. But in the beginning, it just looks like they do because you can't tell what they're feeling from their face. So you're going to give medications to try to increase the dopamine. The patient should know that by increasing the dopamine, you should have less of these symptoms, but the Parkinson's disease will never go away. Once you have it, you can only hope to slow down the symptoms. So these medications are lifelong, and you can only hope that by kind of decreasing these symptoms, the patient will be able to care for themselves as long as possible and actually be able to do their activities of daily living. And that's the goal of therapy. So if there's a question about that on the exam, what is the overall plan, or how do we help this patient? It's for them to maintain their independence as long as possible and decrease these symptoms, but we won't cure them. So the drugs that we're using to increase available dopamine are Levodopa-Carbidopa, which is a synthetic dopamine, Pramipexole, which is a dopamine agonist, so it acts like dopamine in the basal ganglia area, and selegiline, which stops the breakdown of dopamine. So if we were thinking about where those medications were acting, we always have to think about that nerve picture. So there's the first nerve that has the vesicles, in this case, dopamine. There's the synapse space, and then there's the next nerve that's going to go down and provide some kind of action on the muscle. This nerve has receptors on it. So the way the medications work is, one, is they can add dopamine. So even though the neurotransmitter might not be putting out as much, or there's less nerves releasing dopamine, this nerve that's still functioning, we're going to increase the amount of available dopamine in the synapse. Or it could act like dopamine on these receptors, or it could prevent the breakdown of dopamine in the synapse. Because once the nerve releases the neurotransmitter, after a while, we're supposed to clear that neurotransmitter so that the nerve can accept a response again at some other point. So the way the body does that is to recycle some of the neurotransmitter with reuptake and have enzymes that break down the neurotransmitter. So those are the way the medications will work. The first one is Levodopa-Carbidopa, and levodopa is a precursor to dopamine. In the bloodstream, it isn't, in the regular peripheral bloodstream, it isn't dopamine, it is levodopa. When it crosses the blood-brain barrier, in the brain, it becomes dopamine. The carbidopa is added to prevent the levodopa from being metabolized and eliminated from the body before it gets to the brain where it needs to work. It does take a little bit, 6 months, for the person to actually see the benefit of the medicine. You should take it with food. Lots of times people have nausea and vomiting with these types of medicines, and food helps with those symptoms. But foods that are high in protein should be avoided at the time of taking the medication because that could decrease absorption. Levodopa-carbidopa comes in different release forms. There's extended release and short acting. And people sometimes have to take a combination of both in order to maintain a therapeutic level in their bloodstream, or they will have what's called on-off effects. So sometimes they'll have the effects of the medication, they'll have decreased Parkinson's symptoms, but if their level in their bloodstream decreases even a little bit between doses, they're going to have an increase in their Parkinson's symptoms. So it can be hard to manage from patient to patient. So we're taking it with food to decrease nausea and vomiting. People will notice a darkening of their urine and sweat, but this is harmless. It's not because of a problem. It's just something they should be aware of. They can have orthostatic hypotension, so it's very, very important that they know to change their position slowly since they're already a falls risk having Parkinson's disease. They have the stooped posture and already their center of gravity has changed, so we really want to be careful that they don't fall at all. And even though you're taking the medication, because the patient is having tremors and problems with contraction of muscles, it's possible that they'll develop a different type of tremoring called dyskinesias or tardive dyskinesias. And these are different from the tremors that people have, to their hands and that when they have Parkinson's disease. This is tremors that occur on the face or grimacing gestures or their head bobs. They might smack their lips or stick out their tongue or blink excessively. So that can be hard for people to deal with. It's very visible when someone is experiencing a dyskinesia. It could be a reason for them to try to change medications, but it might just be something they have to deal with because the medication will help them be able to take care of themselves. It's just that then they'll have to see these other distressing symptoms. There's multiple cautions and interactions with levodopa-carbidopa. It is contraindicated in glaucoma, melanoma, and people with suicidal thoughts. Pramipexole is the medication that works like a dopamine agonist, so that's the one that works here on the receptor, even though it isn't actually dopamine. It's taken by mouth, again, should be taken with food because it can increase nausea and vomiting if taken on an empty stomach. Again, we have to worry about orthostatic hypotension. Again, we have to worry about those dyskinesias, so similar issues. This, however, has a different effect called sleep attacks, which also I think would be difficult and could increase the person's falls risk. A sleep attack is sort of like narcolepsy, where the patient is going about their business and suddenly their muscles become very weak and they might fall asleep. And it could be that they just need some dose adjustment, but that is something they should be warned about. And then the last medication for Parkinson's disease that we're going to talk about is called selegiline. And this medication works by inactivating the enzyme that would get rid of dopamine in the synapse. So that particular enzyme is called MAOB, And that enzyme, once dopamine has been released, is supposed to clear out the dopamine in the synapse to get rid of it. If we inhibit that enzyme, then dopamine will stay in the synapse longer, and the effects of dopamine will last longer. This medication is an oral disintegrating tablet, so that means it would just sort of melt in the person's mouth and be absorbed in that way. However, you kind of have to move the pill around in different spots of the mouth when it's absorbing, because it could lead to ulceration or tongue irritation. It can cause fairly bad insomnia, so the medication should never be given after 12 p.m. It should always be given in the morning. And tyramine foods also require MAOs to break them down, so you need to avoid tyramine foods. Yes, you could put it sublingually. You could put it against the buccal membrane. It just has to absorb in the mouth. I don't know if you've ever given anyone like an oral disintegrating tablet for Zofran or ondansetron, which is for nausea. It's similar to that. All right, we'll talk about the two Alzheimer's medications and then we'll take a break. So those were the three medications for Parkinson's disease: Levodopa-Carbidopa, Pramipexole, and selegiline. Now we have two medications that we're going to talk about that are for Alzheimer's disease. So the issue with Alzheimer's disease is degeneration of nerves in the central nervous system in the cortex of the brain. And those nerves use acetylcholine. And it's not just the frontal area, the frontal lobe. It can be frontal, parietal, temporal lobes, occipital lobe. Eventually, it'll cause the full brain's nerves to degenerate. It typically starts in the frontal lobe. So patients will start, the symptoms they usually start to have are short-term memory deficits and issues with executive function. So managing your bills, scheduling appointments, things like that. But they're able to still accomplish activities of daily living and still can take care of themselves, and in the very beginning can do things to sort of hide this disability. As things progress, they will be less and less able to care for themselves, will be more of a safety issue because they're not going to always know what's going on. And then in the end, they really can't do anything for themselves and can be more towards a vegetative state. People usually don't die of Alzheimer's disease itself. They die of complications of being bedridden in a nursing home, like urinary tract infections or pneumonias or things like that. So if the patient is starting to develop memory issues, it's best to start to treat this as early as possible. The first drug that was developed is called Donepezil, and this is a cholinesterase inhibitor. We talked about a cholinesterase inhibitor that operated in the peripheral nervous system, and that was the medication for myasthenia gravis. That was a cholinesterase inhibitor. The medication was pyridostigmine or endonorphium, the one that's used for diagnosis. That medication is supposed to decrease breakdown of acetylcholine in the peripheral area where the skeletal muscles are working in order to decrease the weakness that the person was experiencing. This is supposed to occur, this inhibition of the breakdown of acetylcholine is supposed to occur in the central nervous system, in the frontal brain especially, because if there are nerves that have been damaged in the frontal brain, making it difficult for the patient to remember things and stuff like that, then if we increase the amount of acetylcholine that's available with the nerves that are remaining, it's possible that we can improve their memory and functioning. It takes a couple of weeks for it to work, and it's a modest improvement. It's not like you're like, wow, they're fine, they're back to normal, but it does seem to improve things a little bit. It does cause insomnia, so it should be taken in the morning, nausea and vomiting, so it should be taken with food. The biggest issues are here. It can cause a decrease in heart rate. So we know that we only wanted to take care of acetylcholine or increase the amount of acetylcholine in the central nervous system. It's possible that we'll also do that in the peripheral system, specifically in the parasympathetic area, which could decrease heart rate and potentially lead to syncope or the patient fainting. The other issue, which you don't exactly know the reason, is that especially if the patient is taking Donepezil with NSAIDs like ibuprofen or aspirin, they have an increased risk of GI bleed. So if the patient would start to notice an increase in abdominal pain, or they started having black tarry stools, then that would be a reason to check into that further and be sure that they're okay. And the last medication for Alzheimer's disease is called Memantine. What this does is it decreases nerve damage. This receptor on the nerve, NMDA, if that receptor is activated, then nerves, there's a change in the way electrolytes enter the nerves, and it could cause damage to the nerves. So if we block the NMDA receptor, we can decrease damage to nerves. And this medicine is often taken with donepezil at the same time. So all the medications we've talked about so far today are given with food to decrease nausea and vomiting. In order to prevent toxicity, if the patient has liver or kidney disease, we'll have to adjust the dosage. There could be dizziness, headache, constipation, and increased confusion, which would be bad. I mean, we're trying to take this to decrease those symptoms, but it's possible, especially in the beginning, that the patient feels a little bit worse. So those are our neurodegenerative medications. We will take a break. So right now it's 10:15. So at 10:25, we will resume talking about medications for seizures. So I'm going to stop right here, and then we'll be back at 10:25.